Okay, so I'll introduce myself again. So my name is Nathan Rono. I've just finished my 4th year and I'm going to take you through virology. So objectives for today are papillomaviruses and picornavirus. Okay, so we'll start with papillomavirus. So it's going to be interactive, please. If you have something, if you have a question, type it on the chat. And then I'm going to be asking questions as we move along. I'm sure you've been taught this, so it's going to be quick and fast. Okay. So papillomaviruses. So papilloma, it's called Papoviridae family. They are double-stranded DNA viruses with a protein capsid. Then one thing you should remember, they are small viruses. Okay. They infect human squamous stroke metaplastic epithelial cells. Jackson, do you have something to say? Agutu Jackson? Okay.
No, sorry, I was just trying to arrange myself. Wale.
Okay, no worries. So it infects human squamous stroke metaplastic epithelial cells. So this is something you have to remember, epithelial cells. So you guys have just done anatomy lately. So can you tell me examples of areas where there are squamous cells? Which organs are lined by squamous epithelial cells? So that we know where this virus is going to affect. You can type your answers. Sorry, you can type your answers in the chat. Esophagus, skin stratified squamous, keratinized. Alveoli, yes. So alveoli is simple squamous. So I'm more interested in the stratified squamous. Give me the ones that are stratified squamous. The vagina, yes. Esophagus, yes. Skin, yes. Mouth, yes. And then the anus, yes. Good. So there are 130 genetically distinct HPV types, of which 30 to 40 primarily infects the lower anogenital region. Okay, that's what we're mostly interested in. So the risk factors, early age of sexual intercourse. So we have said the cells we're interested in is in the epithelium of the vagina, the anus, and the mouth. So early age of sexual intercourse, multiple sexual partners, and poor immune function. Okay. So types of HPV. So I'll broadly classify them into 2 types, high-risk types and the low-risk types. So for the high-risk, 16, 18, 31, 35, 45, 58, just remember the big numbers. So from 16 and above, these are the high-risk types. And why do we say they're high-risk? Is because they're oncogenic. Oncogenicity means that they're likely to cause cancer, okay? Then type 16, in invasive carcinoma. So this invasive carcinoma of the cervix, cervical, CIN means cervical invasive carcinoma, cervical invasive neoplasia, which is basically cervical cancer, 2 and 3. So there are types of cervical cancers. That's not relevant now. Then the lower risk are 6 and 11, which cause genital warts, subclinical HPV infections, and laryngeal papillomatosis. Okay, so these are benign. I'm sure you've started pathology. You know the difference between benign and malignant. Benign means that there is overgrowth of cells, but it does not spread. Then malignant means that they'll be spread. So the low risk causes warts, and the high risk causes the cancer. Transmission? So there is by direct contact, usually sexual contact with genital skin, mucous membrane, or body fluids of partner with either warts or subclinical HPV. So I remember when I was being taught 2 years ago, we were told HPV is one of the only infections where you can get it despite wearing a condom. So if your partner has HPV and you wear a condom, you can still get it because it's through sexual contact. Okay. High-risk HPV cervical infections is generally limited to women who have experienced penetrative sexual intercourse. It infects epithelial tissue through microabrasions that exposes segments of the basement membrane. In most cases, infection is multifocal, involving more than one lower reproductive tract site. So what basically this means is, I don't know if I can draw. These are the cells, okay, of the epithelium. So you'll get a microabrasion, so maybe a tear here. Then the HPV virus will enter here, embed itself, and now starts causing pathology, okay? So it usually starts from the lower basement membrane as it goes upwards. I think we're going to see the pathogenesis of this bacteria. Oh, sorry, of this virus. Understood? Okay. Fomite transmission. So this is for the non-genital warts, basically contact. Then the less common ones are oral to genital and hand to genital transmission. Okay, so people who participate in oral sexual intercourse can get it. Then congenital, conjunctival, laryngeal, valvular, or perianal warts present at birth or that appear within 1 to 3 years of birth is likely diagnostic of perianal exposure to maternal HPV, basically vertical transmission, okay? Next, pathogenesis, as I was saying. Persistent infection with high-risk HPV affects the cell growth by the following mechanism. So HPV integrates into host DNA. So we said after the microabrasion, it's going to enter into your DNA. And when it enters to your DNA, what will happen? There'll be overexpression of viral proteins, E6 and E7. This is very, very important. You have to know this, okay? E6 and E7, very important. The viral protein also activates cyclin A and E, permitting further cell proliferation. They also mediate and degrade BAX, apoptotic gene, which inhibits apoptosis. So this you're going to do in pathology. I don't know if you've already done the cell cycle and upregulation of tumor. So there's tumor suppressor genes, for example, retinoblastoma gene, RB gene, and P53. So what happens is they're going to be downregulated. And when that happens is there'll be further cell proliferation. Proliferation means multiplication. So the cells are going to multiply, multiply, multiply. And then they have said it also inhibits apoptosis. Apoptosis basically means cell rupture or releasing its, you know what happens is if there's a foreign cell and the immune system wants to destroy it, it will cause apoptosis. So it's going to burst and die. So when this process is inhibited, the cells will continue multiplying and further proliferating, okay? So we have, can you see here? We have, sorry, E6 and E7. So E6 binds to P53, and we have said what P53 is. It's a tumor suppressor gene. And when it binds to it, it activates E6AP, leading to P53 degradation. When this happens, it's a tumor suppressor gene, meaning that it's supposed to suppress multiplication of the cancer cells. But if it's degraded, what will happen is it will continue multiplying. E7 binds P53, P21, and retinoblastoma gene, RB gene, leading to activation of PRB plus E2F, leading to cell cycle progression. So this will cause unregulated cell cycle proliferation, leading to immortalization or now the cancer. Okay, so the high yield point here, the take home is HPV E6 protein. It binds to P53, which activates the cell cycle. E7 binds P53 and retinoblastoma gene, leading to rapid proliferation. So this is how it happens. I'm going to send the slides. You can take a look on it. And then here is now the risk factors. We said early age of coitus, multiple sexual partners, high risk male sex partners. Then HPV infection, low risk 6 and 11. We have episomal infection, condyloma acuminatum. I'm going to show you. And then for high risk, we have CIN, cervical invasion neoplasm, basically cervical cancer, okay, leading to invasive cervical cancer. Then outcomes of HPV infection. Latency. Well, latency basically means a period where the virus has implanted into your DNA, but it does not cause any clinical features. So it is latent. Basically, it is hiding, okay? So when you become immunocompromised, as we said, as a risk factor, there'll be condyloma formation, leading to subclinical infection. And this subclinical infection can lead to intraepithelial neoplasia or spontaneous clearance. So basically, your immune system can fight it, then it goes away. If that doesn't happen, it can progress to invasive carcinoma, which is the cervical cancer. Okay. So cells are infected, but HPV remains quiescent, which is basically quiescent basically means that they're hiding, but they do not cause infection, okay? Viral genome is intact, not integrated into the host cells, no detectable tissue defects at the latent stage. But productive HPV infection, there'll be completion of viral life cycle, basically proliferation and increase in the number of viruses. Oncogenes are expressed in very low levels. Both males and females produce either genital warts, the condyloma acuminata, or subclinical features. Subclinical infection may be indirectly identified in cytology as LSIL. Okay. Then this is for cervical cancer. This is how it goes. I think I had explained in that slide. And then condyloma acuminatum. These are anogenital warts. You can see here, this is the labia majora. You can see these are the warts. Okay. So basically, if you see this, if you get contact, it is got by contact transmission. Okay. Usually there are multiple forming soft warty masses. Common sites, as we said, where we have stratified squamous epithelium, the anus, perineum, vaginal wall, and the vulva. Okay, caused by HPV 6 and 11. Because we know they are warts, so they are benign. So this is caused by the low risk, so which is 6 and 11. Then microscopically, you will see something known as coecylocytosis. Here they are, the coecylocytes. They are perinuclear vacuolization. Yeah, there, can you see them? With the halo ring, this blue part, then here's the nucleus, okay? This is under pathology. So treatment, they regress spontaneously, but you can give them these drugs, Odophilox, imiquimod, and secantecin. But this is more pharmacology, so don't worry. Then for diagnosis, an important thing is screening, very, very important. So we screen through cytology, histology, and colposcopy. The most important thing is, we call it pap smears. So pap smears is done routinely in women. This is now the cervical screening in greater than 30 years old. A triage of surveillance of abnormal cytology results. And then we have post-treatment surveillance. So detection of HPV DNA. So this is done by a PCR polymerase chain reaction. You get to see this, the HPV DNA, okay? And then in cervical cytology and HPV tests are negative, you know that, okay, you are safe from cervical cancer. So what happens is pap smears. So where, who knows what a pap smear is? Oh, someone is saying I'm going too fast. Sorry, where did I leave you? I can go back, but who knows what a pap smear is? Any answer? Nobody knows what a pap smear is. Mm-hmm. It's a discussion. If you don't know, I'll tell you.
I think it's just a test for that is being done to any reproductive age of a woman, to diagnose whether they have got either a cervical cancer.
Mm-hmm. So it's a screening test.
Yes.
Yes, that's good. So let me see if I have a picture. Sorry, can you still see my screen?
Yes.
So here it is. So you can see this is a speculum. So they open up, then it's the pap smear brush.
Hi, Nathan.
Yes.
You're still on the same screen.
Oh, okay, sorry. Let me... Can you see it now?
Yeah, good.
Okay, so this is the speculum. Then here's the pap smear brush. Can you see it? So it's usually here. So we are targeting, these are the cells we're targeting. So we will target the vagina, the vulva, and the cervix, okay? So we take a swab, then we take it to histology. Then on histology, we are going to see if you're going to see those cells that we had mentioned, okay? The coilocytosis, okay? Those are the ones that are relevant, okay? So is that okay? So that's what is pap smear. So cervical screening method. So we are actually there. So it can detect CIN2 and 3. These are the types of cervical cancers effectively. So pap smear testing here, can you see it? A typical smear after excluding infection. Then HPV testing, positive for high risk HPV. Colposcopy is where we go take a biopsy. So a biopsy is basically we go here, we go remove some tissue. So here we're interested in the cervix. So we remove a part of the tissue, then we go test it for HPV. Okay, that's colposcopy. And then if it's negative, repeat the smear after 1 year. Okay, I hope that's understood. And then we go to prevention. So HPV vaccines, these are quite common. And I think they usually give girls in high school, if I'm not wrong. So they're safe and well tolerated. Synthetic production of L1 capsid protein for each HPV, highly immunogenic. So the high yield you should know is Gardasil, quadrivalent vaccine, So it's relevant for type 16, 18, 6, and 11. So high risk and low risk. Then Cervarix, bivalent vaccine. So type 16 and 18. So doses, there are 3 doses. You take in 6 months. Ideally, before commencement of sexual activity. So 12 to 18. So that's when you're in high school, isn't it? Then effective for about 7.5 years. So what happens? What do you think happens after, let's say you've started you have had your sexual debut and you're like 30 years old? Do you think we should give them vaccines? Just type on the chat. It's a yes or no question. So you have a 50% chance of getting it correct. No, okay. Why? Why do you think we shouldn't give them vaccines? So basically, after your sexual debut, what happens is the method of here, we are interested in more of treating it or prevention of getting it. So we'll be giving you'll have regular pap smears, okay, rather than the vaccines, because vaccines are a prevention mechanism. You don't have the disease, but now if you've started having sex, we are interested in checking if you're going to get it. So we do regular screening, okay. Then number 2, use of condoms. They prevent HPV transmission through bodily fluids and across mucosal surfaces. But we said condoms can be less effective. So reason being is it's spread through contact. Yes, but you can also get it through body fluids. Behavioral interventions, so sexual abstinence, delaying coitus, limiting number of sexual partners, maintaining hygiene, local hygiene, and treat vaginal infections. So they tend to co-occur. For example, if you have gonorrhea, you may have chlamydia, these bacterial vaginal infections, so they may co-occur with HPV. Then male partners should also maintain penile hygiene, as it may be a reservoir for high-risk HPV. Remember, we said, had we mentioned the penis? Yes, and then quit smoking. So smoking has been shown to increase the risk of getting, like if you smoke, it increases your chances of getting HPV. Okay. And then another one that I've not added is circumcision of males. So uncircumcised males can harbor the high-risk HPV. Then obviously immunosuppression. So if someone is immunosuppressed, for example, if you have HIV, or you're taking chemotherapy drugs, or you have systemic diseases like diabetes mellitus, those ones can give you, it increases your risk of getting HPV. Okay. Yes, and then damage to the sexual organs. So for example, if you've had, as you remember, we said here, we said, where is it? If there's mucosal laceration, you remember, and I was drawing for you microabrasions. So if there's damage to the epithelium, it's easier for the DNA to, the virus to embed into your DNA. So if you have any trauma or lacerations in the epithelium, it's going to increase your chances of getting HPV. Okay. Is there any other one? Yeah. Then we go to, okay. Do you have any questions? Let me check the chat. Tiny collector swab from the cervix. Yes. Why do screening and yet they aren't sexually active? Agutu Jackson, sorry, I don't understand your question.
No, just thinking about, we talked about the risk factor being having multiple sexual partners, being sexually active. And then if we said you've abstained and you're less than 30, then I was thinking, why then are we doing the screen? And yet I know myself that I've been perfectly okay not engaging in sexual activity.
So as a doctor, yeah, I mean, that's a good question. But as a doctor, you assume the worst. So that's why we advise, because I mean, abstinence, if you abstain, as we said here, behavioral intervention, sexual abstinence, if you abstain all these things, you won't get these diseases. All the STIs that you know, you won't get them. But now, since we know that HPV is a very deadly disease and it gives you cervical cancer, we just advise for screening. Okay?
Okay, sawa.
Yeah, but it's usually advised that once you turn 30 and you did not get the vaccine when you were young, you just do cervical cancer screening. Okay. And then I'm seeing, how does smoking increase the chances of catching HPV? So I'm seeing Jackson has answered you, due to cellular changes in smokers. Yeah, so, smoking is very bad, very, very bad. I don't know why it's actually even in the market, because smoking has no increased risk at all. Has no benefit at all. The only good thing about smoking that I've ever seen from the literature I've read is there's a disease called ulcerative colitis. So basically, it's a disease that affects your GITs, your GI tract, and it reduces the risk of getting that disease. And that is the only benefit thing I've seen from smoking. Other than that, I've never seen any benefit that smoking does. So what smoking does is it destroys your epithelium of all epithelium, from the alveoli, mouth, the vagina, all epithelium lining your whole GI tract, reproductive tract, all the systems you may think of. And once that happens, HPV will easily protrude to the epithelium and cause cellular damage. Okay. So advice, quit smoking at all. Like, don't smoke at all. That's all I can say. I think we are done. So maybe a few questions, then we can do a quick recap then, or try and answer these questions, then we can do a quick recap. Identify 4 cancers caused by HPV 16 and 18. So these are the high risk ones. Yes, so everyone should tell me. Let's start with Agutu. You name one cancer. Agutu. Agutu. One cancer. We have mentioned so many.
Cervical.
Cervical, yes. Anzal, one cancer. Anzal. Or you can type, those who can't unmute. Anal, yes, good. Next we have, let me check the participants. Janet Kuria, one cancer. So we have said cervical, we have said anal. Janet.
Penile cancer.
Penile, good. Navia, Aurora.
Vaginal.
Vaginal, good. Sanskriti. One more. There's one more. In fact, there are two. Good. Valvular and oropharyngeal. Yes, good. Next question.
Hi.
Hello. Oh, Steve. Yes.
Could oropharyngeal be part of this or it's not?
Yes. So it lines the oropharynx. So yeah.
Okay, fine. Okay, thanks.
Next question. Which of the following HPV tests is responsible for majority of genital warts? So who has not spoken today? We go back. So Agutu.
16.
16? Genital warts. What did we say about genital warts?
Genital warts are from low risk. I think it should be 6 and 11.
Yes, 6 and 11. So what's the answer?
C.
Yes. Good. So we said 16 and 18 are the high risk ones. So genital warts are benign. So these are the low risk ones. So 6, 11. Okay. Next, who's going to answer this? Overproduction of which of the following proteins is most likely involved in the pathogenesis of cervical cancer caused by HPV? Anzal. E6, oncoprotein. Good. You see, these things are easy. So E6 and E7. Next. I'm going to read for you. This is a long question. So who will answer this one? Janet. Let me read. A researcher is studying the molecular mechanism through which HPV infection leads to cervical cancer. He has developed an in vitro model that involves transfecting cervical epithelial cells grown in culture flasks with a lentivirus carrying the HPV E6 and E7 genes. The expression of protein E6 and E7 in infected cells is subsequently confirmed using fluorescence microscopy. Which of the following best describes the role these proteins play in the pathogenesis of cervical cancer? So it's a long question, but the question is, what is the pathogenesis of HPV causing cervical cancer? So is it A, B, C, D, or E? So whose question was this? Janet?
The answer is A.
A, inhibition of cell cycle regulatory proteins. Good. So which are these ones? So they are P53 and retinoblastoma gene. So those are the tumor suppressor genes. So when you overexpress E6 and E7 will cause downregulation of those or inhibition. Yes, so we can do a quick recap of what we said on HPV. I'm sure, I hope you have understood. We started by saying HPV is double-stranded, circular, non-enveloped DNA virus. We said it's small, can be divided into two. Oh, I think. Okay, it can be divided into two. There is low risk and high risk. Low risk is 6 and 11. 6 and 11, they mostly cause anogenital warts. Okay. Then high risk, we mentioned at least 6 cancers: vulval, vaginal, penile, cervical, the most important, and there's also oropharyngeal and anal. Okay. Those are the high risk, which are 16 and 18, most important ones. And then we said route of transmission, most of them is close contact and sexual transmission, or even mother to child, okay? But if you're asked the two main ones, you say contact and sexual contact, okay? Then we said risk factors. We have immunodeficiency, unprotected sexual intercourse, early coitus or early sexual debut. And then we said now increased number of partners, smoking, uncircumcised males, okay? Then we said pathogenesis, we have increased E6 and E7 oncogenic proteins, leading to downregulation or inhibition of P53 and retinoblastoma gene, embedding into the epithelial cells, causing embedding into the DNA of our epithelium, leading to proliferation. And in this proliferation, there's also inhibition of apoptosis, causing the cancer, okay? Then on pathology, we said we're going to find, what did we call them? Poilocytes, okay? Where are they? These ones, okay? Yes. And then manifestations, we have condyloma acuminatum. These are anogenital warts caused by low risk. And then we have cervical cancer. Then we went to how to prevent. So I want each and everyone to tell me one way of preventing cervical cancer. Where were we? We were at Navia.
You can avoid having many sexual partners.
Yes. So it can be an SAQ question. They're going to ask you 5 ways of preventing HPV. So yes, so limit the number of sexual partners. Good. Sanskrit. Steve.
We can talk about abstinence.
Abstinence, yes. Badri. Was Badri here when we started? V. Badri. Yep, Sarah. Local hygiene, good. So cleaning of your penis and vagina, yes. Agutu, Jackson, Anzal, Janet. Tell me one.
Vaccination.
Yes. So we should have started with that. Which 2 vaccines did I tell you have to know?
Gardasil and Cervarix.
Good. Any other one? Quit smoking, good.
Use of condom.
Yes, use of contraceptives, like barrier method, for example, condoms. But we said it's not that effective because you can get spread by contact, isn't it? Yeah. Then we go to, I think we're done with HPV, unless you have a question. Pap smear, no one has mentioned pap smear, regular cervical cancer screening. Any other question on HPV? Now I want to show you something.
What about you talked about colposcopy also?
Yes, or where we go take a biopsy. So that is when we want to confirm if you have cervical cancer. We are going to go stain, look under a microscope, and see if you're going to see the coilocytes. So I want to show you something. I know they love. Do you guys have a group?
We have a Telegram, not a WhatsApp.
Oh,
So
okay.
there is our medic group, I think.
Oh, so I want to show you something. This one comes in exam so many times. I remember it also came in ours. Can you see my screen? Can you see this person?
No,
No.
we're just seeing previous screen. Yes,
Can you see him?
yes.
What do you think this is?
Look, are those words?
Yes, but they have a name. Yes, they are caused by HPV, but what is this?
Condylomat.
No. So it's called epidermodysplasia verruciformis. Okay. So you see how the warts start. They start as cutaneous warts, then they can progress to this. It's called tree-bark appearance. Okay. Epidermodysplasia verruciformis. So if you see this, they can bring a spot, then they tell you what is the causative organism. So it's HPV. Okay.
Sorry, the name again?
Epidermodysplasia verruciformis. Let me type on the chat. Epidermo. So the epidermis. Epidermodysplasia verruciformis. There. Oh, sorry, I've sent it to someone else. There. Then another question they like asking is,
They bring the images.
yeah, there's something called spot. You've not been told?
No, we've been told, but specifically to immunology, virology.
Oh, yes. They'll bring you. So they'll bring an image like this, then they ask you. So for example, you'll be told, list two, how would they frame it? They tell you which HPV types cause this manifestation, 2 marks. What will you say? Hmm?
6 and 11.
6 and
11.
11. Good. So this is cutaneous what? Okay. Any question on HPV? So HPV, I hope everyone has understood. Make sure you go through it. They can bring spot images. Make sure you know those images. And SAQ they give you 5 preventative methods of HPV. But they tell you list the 2 types of HPV, low risk and the high risk. So I think we can continue. Hello, can you see my screen?
Yes.
So, first of all, before I continue, do you know the classification of viruses in terms of DNA, RNA, enveloped, non-enveloped? Do you know? Have you been taught? Oh, yes, you've been taught. Good. So if you are to classify picornaviruses, are they RNA viruses or DNA viruses? Are they DNA or RNA viruses? Then are they enveloped or are they non-enveloped? Let me see who will answer this question. So they're RNA viruses. Yes. So they're enveloped or non-enveloped? Husena, Mamuji. Husena? RNA. So it's the type of virus is from the name. So pico-RNA virus, picona or picornaviridae. So pico means small. Then there are RNA viruses. Okay, picorna virus. Okay, so they are small, non-enveloped RNA viruses. So before I continue, have you done picornavirus in class? No? Oh, I was told you did. So this is a lecture. Had you done HPV?
Yes, we did.
You had done HPV, but you have not done picorna.
Yes.
Okay, so don't worry, it's simple. So these are small RNA viruses. They're non-enveloped single-stranded RNA viruses with a cubic symmetry. So the virus capsid is composed of 60 protein subunits, each consisting of 4 polypeptide VP1 to VP4. Because they contain no essential lipids, they are ether resistant. They replicate in the cytoplasm. Very important. Very, very important. Okay. Very, very important, okay? Where do they replicate? In the cytoplasm. You have to remember that. Yeah. There are very many. So the most relevant ones are enterovirus, rhinoviridae, and hepatovirus. So enterovirus are your polio, Coxsackie, okay? Rhinoviridae is what we know as, we call it Homa. Do you know when you get a flu, every time you get a flu? So the next time your parents or anyone gets a flu, you tell them, you know, I know you have rhinoviridae, you have rhinovirus, so that they're impressed. You know, as a medic, these are the small things you tell people and they get very impressed. Tell them you have a viral infection, so don't use antibiotics. We don't use antibiotics for viruses. Okay, so that's rhinovirus. It's the normal flu we get. So everyone has gotten rhinovirus. Then hepatovirus is hepatitis A. How many hepatitis do you guys know? Have you heard of hepatitis virus? Yes, A, B, C. Actually, there are 5, A, B, C, D, E. So here we are interested in hepatitis A. Hepatitis B has another classification. I thought the flu we get normally is influenza. I mean, the most common one is rhinovirus. Influenza is more of a serious disease, but yes, we usually get influenza. Rhinovirus is usually self-limiting. Influenza is more serious, okay? But we also get influenza. Yeah. Next. So the Picornaviruses family has 5 genera: enterovirus, hepatovirus, rhinovirus, aphthovirus, and cardiovirus. Ignore these 2. This one affects rodents. So we're interested in enterovirus, hepatovirus, and rhinovirus. Okay. Let's start with, also here's the table. You can see enterovirus, we have polio, Coxsackie. Rhinovirus is the flu we get. Ignore these ones for rodents. Hepatitis A virus, ignore these 2. This one is also called foot and mouth disease virus. Not that common. So focus on these 3: enterovirus, rhinovirus, and hepatovirus. Yeah. Clinical manifestations. So we are starting with enterovirus. Enteroviruses are stable under acidic conditions and thus are able to survive exposure to gastric acid. Okay. Enteroviruses are implicated in many diseases, including undifferentiated febrile illness, fever with uncertain cause. So if you come with a fever and I'm trying to look for the cause and I cannot find it, I'll think of enteroviruses. Upper and lower respiratory tract infections. So anytime you see someone with a flu, symptoms of flu like cough, runny nose, fatigue, you know, general symptoms, think of enteroviruses. GI disturbances, for example, you feel nauseous, you feel like diarrhea, vomiting. Conjunctivitis, this is inflammation of the conjunctiva. So they'll present with itchy eyes. Okay, so depending if it's a virus, so this enterovirus, they'll have a fluid in the eyes, usually stringy in appearance, and it's clear. If you compare conjunctivitis for bacteria, it's usually whitish in color and very thick fluid. But for enterovirus, conjunctivitis is usually clear and very itchy. Skin and mucous membrane lesions. So you'll see them on the skin. They appear as like ulcers. And then diseases in the central nervous system, muscles, heart, and liver. So most likely polio, okay? Then less commonly, enteroviruses associated with general neonatal infections, DM, pancreatitis, inflammation of the pancreas, orchitis, inflammation of the testicles, and then occasionally HUS, but these are less common, so don't fret. So these are the most important you should know about enterovirus. So we start with polio. We said there's polio. We also have Coxsackie, but the most important here is polio. So polio, I'm sure you've heard of polio. What do you guys know about polio before I tell you? Tell me anything you know about polio.
It causes paralysis.
Yeah, it's associated with paralysis. Yes. Anything else? Have you ever heard of polio vaccine? Remember when you were children, they used to give you oral drops. Those are for polio. Spread through oral fecal. So it's called fecal oral. So when naming a route, we start from where it has come from to where it is going. So it's fecal oral. If you say oral fecal, it means the infection has come from the oral going to the feces. No, so it's fecal oral. So yes, it's spread via fecal oral route. That's why we give the vaccines, because you can imagine if you don't wash your hands or you dispose your garbage badly, yeah, you can get it. You can get polio. And so it causes paralysis. The fecal oral. What else do you know about polio? It has a vaccine. Yes, so those are good. So polio, also known as poliomyelitis or infantile paralysis, is an infectious disease caused by poliovirus. There is muscle weakness resulting in inability to move. This can occur over a few hours to few days. You know, one thing about polio is in Kenya, it was eradicated since there's so much vaccination. I've never seen patients with polio in this day and age, but during our parents' time, during the 80s, 70s, there was so much polio. 19. So one thing I noticed is, have you ever seen these street beggars? Like when you go to town or any other street, you see so many beggars in wheelchairs or some on the floor. If you get to talk to them, they'll tell you. I've spoken to a few, and most of them usually have polio. So they'll tell you, oh, they came from a poor background, they didn't get the vaccine, and unfortunately they got paralysis. Yeah, so it's quite sad, but these days you won't see polio due to vaccination. The weakness most often involves the legs, but may less commonly involve the muscles of the head, neck, and diaphragm. So you'll see most of them are paralyzed in the legs. And by the time it reaches the diaphragm, you expect this person won't be breathing, so they won't survive. But fortunately, 70% of infections show no symptoms. So polio is mostly asymptomatic. Now I have a question for you guys. This is usually asked in exams. What percentage of polio do you think proceeds to paralysis? Hmm? 30? Oh, that is really big. No, that's too much. That is a lot. 5, still a lot. It's actually 1. So 1% of the people who get polio, only if I get 100 people who get polio, I'll expect 1 or 2 people will proceed to paralysis. Okay, so it's not that common for you to get paralysis. Okay. Years after recovery, post-polio syndrome may occur with a slow development of muscle weakness, similar to that of the person to that which the person had during the initial infection. Poliovirus is usually spread from person to person through infected fecal matter entering the mouth. So we called it fecal oral route. So the symptoms: fever, sore throat, headache, vomiting, fatigue. See the very generalized symptoms: back pain or stiffness, neck pain or stiffness, pain or stiffness in the arms or legs, muscle weakness or tenderness, loss of reflexes. So reflexes are basically, I'm sure the most common reflex you guys know is the knee jerk or the patella reflex, where if you hit the patella, the leg extends. So if you get polio, there'll be loss of that reflex, severe muscle aches or weakness, then loose and floppy limbs. It's called flaccid paralysis. Okay. Then prevention. So here, if I go to prevention, treatment. Before prevention, maybe I can mention pathogenesis. Sorry, I had not included in the slides. But for pathogenesis, basically, if you get this virus, the virus will go to the bloodstream. After going to the bloodstream, it will go to the lymph nodes. After going to the lymph nodes, it may enter the CNS. Now, when it goes to the CNS is when you start getting these CNS manifestations, like muscle weakness, loss of reflexes, and floppy limbs, sorry. Okay. It can also cause, for example, meningitis. If it goes to the meninges, it can cause meningitis. Okay. That's why we have neck stiffness and neck pain. Okay. So if you see a patient with neck stiffness or neck pain, think of meningitis. You don't start thinking of polio, you think of meningitis, because the most common cause of meningitis is most likely bacterial, but have this in mind. But since you said polio has been eradicated, so which is a good thing. Okay. Then we go to the vaccine. So here there are two main vaccines that are very, very important, you should know. Two types of vaccines are used throughout the world to combat polio. Both types induce immunity to polio, efficiently blocking person-to-person transmission of wild poliovirus, thereby protecting both the individual vaccine recipients and the wider community. The first candidate polio vaccine, based on one serotype of a live but attenuated virus, was developed by this guy. So attenuated, I'm sure you've heard this term before. So attenuated basically means weakened. So it's a weakened form of the virus. And when you have a weakened form of the virus injected to you, what happens is you develop antibodies against this virus. So the next time you get such an infection, you'd be able to handle it. Okay. So this is live attenuated. Then the second one was developed by Jonas Salk. It's called the Salk vaccine, or inactivated poliovirus vaccine. It is based on poliovirus grown in a type of monkey kidney tissue, which is chemically inactivated with formalin. I remember this question. Sometimes the lecturers, if you want to see if you know this, if you get a distinction. So they asked which type of virus was grown in a monkey kidney. So it was the poliovirus. Okay. Yeah. Then another vaccine, Sabin vaccine. So this is the one we use. It is the oral, another live oral polio vaccine. So this is the one we were given during immunization. It was produced by the repeated passage of the virus through non-human cells at physiological temperatures. The attenuated poliovirus in Sabin vaccine replicates very efficiently in the gut, the primary site of wild poliovirus infection and replication, while the vaccine strain is unable to replicate efficiently within nervous system tissue. Because the oral polio vaccine is inexpensive, easy to administer, and produces excellent immunity in the intestine, which helps prevent infection with wild virus in areas where it is endemic, it has been the vaccine of choice for controlling poliomyelitis in many countries, including Kenya. Okay. So the two main vaccines that you should know is Sabin, which is the live oral polio vaccine, and Salk. Okay, Salk vaccine, which is, this one is the Salk vaccine compared to the Sabin. So Sabin is oral, Salk is intramuscular. It's given intramuscular. So you take an injection and you administer it through your muscles, okay? So which is the most common, the oral or intramuscular? Oral, yes, good. Treatment, there is no cure for polio. You know, most of the time, the viruses usually use antiviral therapy, but for polio, there is no cure. That's why we do preventative measures. The focus of modern treatment has been on providing relief of symptoms, speeding recovery, and preventing complication. Supportive measures include antibiotics to prevent infections in weakened muscles, analgesics, so these are the painkillers for pain, moderate exercise, and nutritious diet. Portable ventilators may be required to support breathing. So in case polio affects the diaphragm, you're going to use the ventilators. Then treatment of polio often requires long-term rehabilitation, including occupational therapy, physical therapy, braces, and corrective shoes. So this is in the case where there is paralysis. Okay. Any question on polio? I have a question for you guys. Does polio mainly affect the motor neurons or the sensory neurons? Motor, good. Sensory, who's saying sensory? Sensory, oh, no. Have I mentioned any sensory features? So it's mainly motor. You see here, we said muscle weakness and tenderness, loose and floppy limbs, severe muscle aches. So all these are motor. If I said sensory, you'd have loss of sensation. For example, to temperature, to pressure, to touch, to vibration, to proprioception, okay? So polio affects the motor neurons. Loss of reflexes. Yes, reflex is a motor aspect. If I hit you at the patella, what will happen? Your leg is going to move. So that's a motor aspect. So sensory is the ones I've mentioned: temperature, pain, pressure, proprioception, those ones. Now, so if they ask you in the exam, where does polio, when polio enters the CNS, let's say the spinal cord, which horn will be affected of the spinal cord? Is it the posterior horn or the anterior horn? Now this, you have to remember your anatomy. Anterior horn, good. The reason is, you remember the corticospinal tract? So what happens is at the anterior horn, it passes through, as it goes from the primary motor cortex, goes to the medulla, decussates, goes to the anterior horn, synapses, becomes a second order neuron, then goes to the NMJ, neuromuscular junction. So polio will affect the anterior horn of the spinal cord. Good. Any questions on polio? So I have a question for you guys. So if you were to take a sample, what sample will you be interested in to find this poliovirus? Stool, yes. Another sample? If you were to tell me 2 samples. CSF, not really. Plus, how will you find it in CSF? You know, you have to culture, and you know, culturing viruses is hard. So you can't culture a virus. So no CSF or a pharyngeal swab. Good. Remember I had mentioned earlier, where does the poliovirus replicate? Remember we said that the oropharynx. Didn't we say that? Did we mention that? Did I mention it? So as nasopharynx swab, isn't it? Oropharyngeal swab, yes. So that's where I'd expect. So a stool sample or a throat oropharyngeal swab, okay? In CSF, you won't find polio. What you'll find is there'll be maybe increased WBCs, increased protein in the CSF, okay? You won't find polio there. I think we're done with polio. Now let's go to hepatitis A. So we have said there are 5. So there are 5 types of hepatitis: A, B, C, D, E. Hepatitis A virus, classified as hepatovirus, small, unenveloped, symmetrical RNA virus, which shares many characteristics of the Picorna family and is the cause of infectious or epidemic hepatitis transmitted by fecal-oral route. You have to remember that. How is hepatitis B transmitted? And how is C transmitted? Who knows? We have said A is fecal-oral. What about B and C?
B can be through fluids, sexual contact.
What about C? Good, that's B. So how I remember for B is just similar to HIV. How do you get HIV? So it can either be sexual contact, blood transfusions, sharing of needles, mother to child. That's how I remember hepatitis B. C is similar to B. So D, what about D? D is similar to B, okay? So B, C, and D, same. Then E is where you get fecal-oral. So hepatitis A and E, fecal-oral. Hepatitis B, C, and D, parenteral, so blood, sexual, perinatal, those ones, okay? Higher. So the virus enters the body by ingestion and intestinal infection. The virus then spreads, probably by the bloodstream to the liver, to the target organ. So it spreads via blood. Large numbers of virus particles are detectable in feces during the incubation period, beginning as early as 10 to 14 days after exposure and continuing. Antibody to hepatitis A virus that persists is also detectable late in the incubation period, coinciding approximately the onset of biochemical evidence of liver damage. So what this means is, so incubation period is the period where you have been infected, you've gotten the virus in your system, but you show no symptoms. But now the antibodies against hepatitis A can be detectable during that stage. And we know that hepatitis A, in fact, all the hepatitis, they cause liver damage. That's why it's called hepatitis. Hepatitis, okay? So inflammation of the liver, okay? Yeah. These are the symptoms: fatigue, sudden nausea and vomiting, abdominal pain or discomfort, especially in the upper right quadrant beneath your lower ribs. So that's where your liver is. Remember, do you remember the 9 quadrants? So in 4 quadrants, it will be the right upper quadrant. In the 9 quadrant, it will be the hypochondriac, right hypochondriac. Clay-colored bowel movements, loss of appetite, low-grade fever, dark urine. So by the time you get dark urine, meaning you're having liver failure, intense itching. So why do you think people with hepatitis A have intense itching, jaundice, and joint pain? Why do you think they itch a lot?
I think it's because of now that the bile that's supposed to be used for metabolism isn't being utilized, then it's being directed into the skin. That is why they are itching.
Good. So basically, due to deposition of bile. So where is bile produced? The liver, isn't it? So this bile, when you have liver failure, this bile can deposit on the skin. They'll have intense itching. It's called pruritus. Same to the jaundice. So jaundice is deposition of bilirubin onto the skin and to the eyes. So you'll have scleral jaundice or jaundice of the skin, okay? Yeah. Unlike other types of viral hepatitis, hepatitis A does not cause long-term liver damage and it does not become chronic. So that's very important. It's usually self-limiting and it's very acute. But for hepatitis B, C, D, it is very bad. It can progress to liver cancer or carcinoma of the liver, okay? In rare cases, hepatitis A can cause sudden loss of liver function, especially in older adults or people with chronic liver disease. So if a patient has chronic liver disease already and then they get hepatitis A, is when now they can get a loss of liver function. Acute liver failure requires a stay in hospital for monitoring and treatment. Some people with acute liver failure may need liver transplant, but it's not common. Liver transplant is common in chronic liver diseases. Hepatitis A vaccine can prevent infection with the virus. So yes, it has. So hepatitis A and B have vaccines. Have to remember that. Hepatitis C has no vaccine. Okay? You have to remember that. So vaccine is given in 2 shots, first one, then a booster 6 months later. Enteroviruses and Rhinoviruses. Oh, okay. So we are done with hepatitis. Any question on hepatitis? I have a question for you guys. Is there a high risk of getting hepatocellular carcinoma in hepatitis A infection?
I don't think so because it is just an acute infection.
Yes, good. We said hepatocellular carcinoma is hepatitis B, C, and D. Okay. It is acute. For hepatitis A, it's acute. Good. Enteroviruses and rhinoviruses may be isolated. So rhinoviruses, so maybe to mention, it is just the common cold. So yeah, everyone tell me a symptom. Let's start with Agutu. Everyone tell me a symptom of rhinovirus. One symptom. I start with Agutu. One symptom. You can type on the chat or unmute. Anzal, Navia, Sanskriti, Steve, Yabsira. Everyone. A symptom of rhinoviruses. Sneezing, runny nose, headache, malaise, good. Good. Fatigue. Yes. Cough. Is cough common in rhinoviruses? Maybe. I mean, it depends on how severe it is. Yeah, it depends. So the more severe it is, the chances you get a cough. Yeah, but most common is runny nose. Okay. So what happens is rhinoviruses, they replicate in the upper respiratory tract. Yeah, even fever. Fever, depending on how bad it is, you can get a fever, but fever is not that common. And it's usually self-limiting. Okay. So it replicates in the upper respiratory tract, in the epithelium of the nasal cavity. Then it causes increase in nasal discharge, which is the mucus. What is it called? Not saliva. Yeah, nasal discharge. It's usually self-limiting. There is no vaccine, there is no drug that can cause. But what usually happens is some people just go for over-the-counter medicine, some antihistamines. The most common people take is cetirizine. Yeah, it can help for symptomatic relief. Yes. Enteroviruses and rhinoviruses may be isolated from feces, pharyngeal swabs, saliva, nasal aspirates, and some enteroviruses may be isolated from skin lesions, conjunctiva, CSF, spinal cord, brain, heart, and blood, but this is not common. So these are the most common, okay? Viruses is present in respiratory and conjunctival secretions from few days before onset of illness to about 1 week later. Virus excretion in feces may continue for several weeks or longer, okay? Control. Education. By the way, if you're asked control in any disease, like literally any disease, is it a parasite, a virus, bacteria, pests, anything fungal, start with education. Okay? make sure you don't forget, because most likely they'll ask you 5. So even in HPV, we didn't do, you should say mass education on the public on HPV transmission, replication, like that, okay? So health education, it's a mark. Stressing the importance of good personal hygiene, provision of good sewage disposal for polio, then fecal and pharyngeal discharges are infectious, hence must be handled with care and disposed. So proper sewage disposal, good toilet, construction of toilets, then vaccines for polio and hepatitis A. Then we said they don't have any antiviral treatment. So treatment is symptomatic and supportive, meaning you treat the symptom rather than the disease itself. And clinical studies shown that ribavirin shortens respiratory illnesses and interferon nasal sprays have prophylactic value for common flus, common colds. But I mean, they're self-limiting. So after 3-4 days, your immune system kicks in and you fight it. Then you're okay. I think I'm done for picoRNA, unless you have questions for me. Any questions? We started 13 people, we're now 7. Now the 6 people gone. Hi, may I have a question for you? Which virus do you think can cause, which virus from the viruses we've discussed today is associated with acute exacerbation of asthma? Which virus is associated with acute exacerbation of asthma from the viruses we have talked about today? Steve?
How about rhinoviruses?
Yes, rhinovirus. Asthma works. So asthma is a respiratory infection. So if you have rhinovirus, yes, good. Yeah. What can I ask you guys? Yeah. Let me ask. Agutu, give me 4 CNS manifestations of polio.
I think one, lower limb weakness, like paralysis.